Welcome to the deep dive. Today we are taking on a tissue that is functionally miraculous, but I think you'll agree, clinically maddening.
Oh, maddening is absolutely the right word, for sure.
Articular cartilage. You, our listener, you've asked for this. A really high-level, practical deep dive into what we call the silent transmission of the joint. We've got a whole stack of sources here, from the basic science to some really advanced imaging.
And our mission today really is to get to the bottom of why this tissue, which is, mostly water, is such a biomechanical tightrope.
Exactly, and why it fails so catastrophically when things go wrong.
That is the perfect way to frame it. I mean, when it's healthy, articular cartilage allows for a whole lifetime of pain-free multiplanar motion.
Right.
It is the absolute definition of functional homeostasis.
Right.
But the challenge for us as orthopedic surgeons is that its durability is directly linked to its biggest vulnerability. It's aneural and it's avascular.
That's the double-edged sword, isn't it?
It is the ultimate double-edged sword. Its mechanical strength comes from that isolation, but that same isolation fundamentally limits its ability to initiate any protective reflexes or mount any kind of effective repair.
It's the ultimate trade-off. You get maximum mechanical performance, but you pay for it with basically zero regenerative capacity. Just look at the numbers we're dealing with. Our sources here note this tissue, which is 80% water, manages dynamic stresses that can reach 20 megapascals.
Which is just an incredible number.
It's staggering. To put that into perspective for everyone, 20 MPa is roughly the pressure you'd experience 2 kilometers deep in the ocean. It's the force required to crush solid rock, and this gel is handling it.
It's absolutely wild. You have to stop thinking of the joint surface as a cushion. It's not. It's a specialized, high-performance bearing surface. It's designed to handle these intermittent, immense pressures without warping, without shedding.
And when that system fails, whether it's from acute trauma or chronic altered loading or disease,
the results are rapid and, more often than not, completely irreversible.
And that's why, clinically, we have to become experts in the basic science here. We can't just be carpenters fixing the final hole in the surface anymore.
Not at all.
We've got to apply these newer concepts like preosteoarthritis, functional tissue engineering, precision medicine. All of it is geared toward catching failure before it's visually apparent on a scope.
We have to understand the structure inside out. Only then can we recognize those subtle biological shifts that are really initiating the disease.
So let's do that. Let's treat this like a case file on this specialized tissue, starting with its functional architecture. All right, so let's get into the nuts and bolts, the basic material components. When we look macroscopically at a joint surface, say a femoral condyle, like the one in figure 27.1, it looks like polished, uniform porcelain.
Smooth, white, glassy.
Maybe 1 to 5 millimeters thick. But the components are, on the surface, deceptively simple. It's about 80% water by weight. And then the dry weight is just dominated by collagens, mostly type 2 and proteoglycans. At its heart, it's a specialized hydrogel that's built to withstand insane compression.
It truly is. But the genius isn't just in the components. It's in the organization of those components. But, before we even get into the matrix organization, we have to talk about the cellular component.
The chondrocyte.
The chondrocyte, which counterintuitively only accounts for about 1% of the tissue volume.
But that 1% is the entire operation, isn't it? It's the manufacturing base, the architect, the builder, the maintenance crew, everything.
Everything. Chondrocytes are derived from mesenchymal stem cells, MSCs, and they are singularly responsible for synthesizing the type 2 collagen and that huge aggregating proteoglycan aggregate that define the entire matrix.
But their working conditions are, well, they're terrible.
They're brutal. They are the ultimate biological paradox. They're essential, but they're completely isolated.
So what are the main challenges of that operational environment? We mentioned avascularity, so no direct blood supply.
Right. And that means all of their nutrition, glucose, amino acids, oxygen, it all has to diffuse through that dense matrix from the synovial fluid.
And diffusion is slow, especially across thicker cartilage, like on the patella.
Very slow. So to cope, they are adapted to extremely low oxygen tensions, a state of deep hypoxia. They have to rely almost entirely on glycolysis for energy, and they function efficiently in an environment that would starve most other cell types in the body.
And what's so interesting, and what the sources really highlight, is that the hypoxia isn't just some challenge they endure, it's a condition they actually thrive in, right?
That's a critical point.
Exactly.
Our sources indicate this low oxygen environment is absolutely critical for maintaining their chondrogenic phenotype. So their identity as a cartilage cell.
So if you take them out of it,
they can dedifferentiate. But sustained hypoxia, say, in a lab setting in vitro, actually increases type 2 collagen gene expression. It stimulates proteoglycan synthesis.
Which is a huge insight for tissue engineering.
A massive insight. If we want to cultivate chondrocytes to repair a defect, we have to replicate that low oxygen tension they require. We have to make them feel at home, or they won't produce the specialized matrix we need.
So the cell is isolated, but it's not deaf. It's constantly responding to signals. How does this lonely little cell actually communicate with those immense mechanical forces we talked about? How does that 20 ampere load get translated into a biochemical signal?
Well, that communication happens through two major pathways. You have your biochemical signals, growth factors, and then you have mechanotransduction, which happens through the immediate matrix.
Let's start with the biochemical side.
So on the biochemical side, the chondrocytes have to regulate homeostasis based on signals like integrins.
Okay, what are integrins doing here?
Integrins are receptors that literally span the cell membrane. They connect the internal cytoskeleton to the surrounding matrix. So when the matrix deforms under load, the integrins physically transmit that force inside the cell, telling it, hey, synthesize more, or okay, slow down.
And what about the key growth factors? What's driving the actual synthesis?
Two are absolutely crucial here. TGF beta transforming growth factor beta and IGF-1, which is insulin-like growth factor 1.
And these are the anabolic signals.
These are the powerful anabolic stimuli. They're often regulated by mechanical loading, and they strongly encourage the chondrocyte to produce more aggrecan and more type 2 collagen. So the cell is constantly in this balancing act. It's weighing these anabolic factors against catabolic enzymes like the MMPs, which we'll definitely get into later.
It's a continuous tiny war being waged by that 1% of cells in the tissue.
A constant war, yeah.
Okay, so let's zoom in on the matrix that's right next to the cell. Our sources break this down into 3 concentric rings of defense. It sounds like some kind of internal bunker system.
It really is. It's a highly organized micro-scale system designed to buffer the cell and transmit forces properly.
Yeah.
So if we move outward from the cell membrane,
What's the first layer?
the first layer is the paracellular matrix. This is the cell's immediate halo. It's rich in water and proteoglycans, but crucially, it contains type 6 collagen.
Type 6, not type 2.
Not
right?
type 2. Type 6 is the anchoring collagen. It tethers the cell membrane to the rest of the matrix network. It provides that essential structural link for mechanotransduction.
So it's both the cell's leash and its signal relay system.
Perfect analogy. This layer essentially filters the forces and regulates the immediate chemical microenvironment of the chondrocyte. It's the cell's own customized life support bubble.
So after the life support bubble, what's next?
Next up is the territorial matrix. If the paracellular matrix is the air conditioning unit, the territorial matrix is the protective wall. It surrounds that paracellular region, and you often see it grouping chondrocytes together in these little baskets, especially in the deeper zones.
Okay, so what's the mechanical function of this basket structure?
It acts as an intermediate layer of specialized padding. It offers localized protection. So when the joint loads, the territorial matrix deforms first, absorbing some of that energy and protecting the central cell and its immediate paracellular layer from, massive acute stresses.
So if you injure the cartilage, you might see localized failure here first before the whole matrix collapses.
That's often what happens, yeah. You see changes in the territorial matrix on histology long before the interterritorial matrix gives way.
And that brings us to the final layer, the interterritorial matrix. This is the bulk of the tissue, right? The heavy lifter we always see on the histology slides.
Exactly. This is the primary volume. It's the material that defines the cartilage's resistance to those big bulk forces. It contains the largest diameter collagen fibrils, and its orientation is what dictates the macroscopic mechanical properties. This is the network that generates and contains that high hydrostatic pressure we mentioned earlier.
And that orientation is the absolute key to understanding its resistance to different forces. So let's shift to that zonal hierarchy, moving from the surface down to the subchondral bone. This is perfectly laid out in the schematic in figure 27.2, both A and B. This anisotropy, the fact that the tissue properties change so dramatically with depth, is just essential.
It's everything. Let's start at the top. The superficial zone. This is the thinnest layer, maybe 10 to 20% of the total thickness.
And the most important feature here is the collagen. It's organized parallel to the joint surface. So why is that parallel organization so critical for this specific layer's function?
Because the superficial zone endures the highest tensile and shear forces,
The sliding, the rubbing.
the tearing actions that happen during joint movement. A parallel organization of type 2 collagen fibrils provides the absolute maximal strength against those lateral pulling forces. It's like having a tight woven net laid flat across the entire joint.
Functionally, it's also where we find that lamina splendens, that thin, cell-free layer. What's the clinical significance of that?
Well, you can think of it as the sacrificial layer. The chondrocytes in this zone are also the ones that produce lubricin, which is a key component of boundary lubrication.
So maintaining the integrity of this surface is non-negotiable.
Absolutely non-negotiable. If this zone gets compromised, even by early fibrillation, you get an acute increase in permeability. Water starts escaping faster under load, and you get an immediate loss of tensile strength. The tissue softens, lubrication fails, and the degeneration just accelerates rapidly down into the deeper layers.
A tiny crack in the armor leads to a total system failure.
Very quickly.
Okay, moving down, we hit the transitional zone. This is often the largest zone, right? Sometimes 40 to 60% of the tissue thickness. It seems to be the main shock absorber.
It is. In the transitional zone, the collagen fibrils are organized obliquely. They form these rotational arches. This intermediate, kind of random but arch-like arrangement lets it handle the complex forces it inherits. You still have some shear, but now you're getting significantly more compressive forces.
It's starting to ramp up the resistance to compression.
Exactly. And you see a compositional shift here, too.
How so?
The water content drops a bit compared to the superficial layer, but the proteoglycan concentration increases substantially. This shift provides greater stiffness and optimizes its function as the buffer zone. It's managing that transition between the tensile resistance of the surface and the pure compressive resistance of the deep zone.
And that brings us to the core compressive layer, the deep or radial zone.
Right. This zone is engineered purely for compression. Water content is at its lowest here, but critically, the PG concentration is at its highest.
And the collagen orientation.
The collagen fibrils here are oriented vertically or perpendicularly to the joint surface.
Why perpendicular? What's the advantage of that?
Imagine trying to squash a stack of vertically lined pencils. They resist that downward force much, much better than if they were just lying flat. This vertical orientation, anchored into the subchondral bone, is what transfers those immense compressive loads straight down into the bone.
And the PGs are just packed in there.
Packed in as tightly as possible, generating maximum internal hydrostatic pressure right in that zone. This vertical collagen alignment is essential for both resisting compression and ensuring that the deep tissue stays securely attached to the bone. If you lose those vertical fibers, the entire structure becomes prone to delamination.
A shearing injury.
A classic delamination injury, yeah.
And that takes us right to the interface, the calcified cartilage zone.
This is the thin layer immediately adjacent to the subchondral bone, anchored by type 10 collagen. This is where the tissue literally turns to bone. It's the physical, gradual transition point. And its boundary with the uncalcified deep zone is marked by the tide mark.
Right, the tide mark. We talk about it all the time in pathology. What is its clinical significance beyond just being a boundary line? Why do we care if it moves?
The tide mark is meant to be a stable boundary. Clinically, in osteoarthritis, we often see the tide mark advance, or sometimes even duplicate. This signifies abnormal calcification and ossification of that deep radial zone.
So you're losing functional cartilage?
You are literally losing the thickness of your functional, uncalcified hyaline cartilage. When the tide mark advances, you are losing the shock-absorbing capacity of the tissue. The whole structure gets stiffer and more vulnerable to microtrauma and subsequent failure. It's a clear sign that the biological regulation of that bone cartilage unit is compromised.
So figure 27.2 is more than just a drawing. It's a map of force vectors. Parallel for tension and shear, oblique for transition, perpendicular for pure compression. It's an absolute masterpiece of zoning.
It really is.
Now that we understand the structure, let's dig into the function. We mentioned that ridiculously low coefficient of friction -0.002. Smoother than ice on ice. But the real secret to surviving that 20 MPa dynamic load is the hydrostatic mechanism. Can we break down exactly how this, again, mostly watery structure maintains its shape under such immense compression?
Yeah, and to do that, we need to completely ditch the image of cartilage as a sponge or some simple elastic cushion.
It's not a memory foam mattress?
It is not. It's a sophisticated fluid pressure system. And the mechanism hinges entirely on the specialized chemistry of the proteoglycans.
Okay, so let's focus on aggrecan, the primary PG. What is it doing chemically that's so special?
Aggrecan is a massive molecule. It looks like a bottle brush. The bristles on that brush are the JEG side chains, chondroitin sulfate and keratin sulfate.
TS and KS.
Exactly. And these side chains are just densely packed with fixed negative charges, sulfate and carboxyl groups. This creates an extremely high fixed negative charge density within the matrix.
And that negative charge density is the power source, right?
It is the generator. It's basic chemistry. Because those negative charges have to be neutralized, they strongly attract mobile positive ions. There's sodium from the synovial fluid into the tissue.
So it's sucking salt into the matrix.
It is. And this rapid influx of mobile cations dramatically increases the internal osmolality of the cartilage.
And high osmolality,
Mm-hmm.
well, physics takes over from there.
Exactly. The osmotic gradient, created by this high concentration of ions, actively draws water, a massive amount of water, into the tissue. And this influx of water generates an intense internal hydrostatic swelling pressure.
So when you compress the cartilage, you're not just squishing a spring, you're pressing against that high internal fluid pressure.
That's the concept of fluid pressurization, yeah.
But if that was the entire mechanism, wouldn't the tissue just swell up like a balloon and disintegrate?
It would, absolutely.
Yeah.
The PGs alone could swell to 4 or 5 times their size. They could push the osmolality up to 450 millism or even higher. This is where the type 2 collagen network plays its absolutely essential restraining role.
It's the containment unit.
It's the containment unit. It acts as a highly disciplined, non-extensible pressure vessel. The interwoven fibers prevent the PGs from expanding excessively, and they lock that high internal fluid pressure into place.
So the collagen is the pressure vessel, and the PGs and water are the highly pressurized contents. It's genius.
It is. And it explains the biphasic behavior. Under a compressive load, the solid matrix, the collagen and PGs, deforms very slowly, but the primary resistance is borne by that fluid pressure.
And as the load persists?
As the load persists, fluid is slowly exuded through the permeable matrix, which causes the surface to consolidate and provides lubrication. That's the weeping lubrication mechanism we learned about.
That distinction between static and dynamic loading becomes crystal clear when you understand these fluid dynamics. We talked about the massive numbers, 3.5 MPa static versus 20 MP dynamic.
And the difference in strain is what's so telling. When we handle a peak static stress of 3.5 MPa like holding a sustained stance or a deep squat, the load is long duration, minutes.
So the water has time to escape.
It has time to escape. This leads to tissue consolidation and pretty significant strain, maybe 35 to 45%. The collagen network eventually has to bear the load as that fluid pressure dissipates.
But the peak dynamic stress, the jump, the landing, the sudden turn is 20 MPa, but it lasts less than a second.
In that fleeting moment, the fluid literally has no time to escape. That high internal fluid pressure generated by the PGs is instantly engaged, and it absorbs the impact with minimal deformation, maybe just 1 to 3% strain.
Wow.
It just demonstrates the incredible efficiency of the hydrostatic mechanism under rapid impact. And that's why healthy cartilage is so resilient to trauma.
This incredible sensitivity to load duration leads us directly to what our sources call the Goldilocks principle of mechanical signaling. Chondrocytes are listening to these cues, and they need that movement. It can't be too much, can't be too little.
They absolutely require a specific, healthy range of dynamic loading. Dynamic cyclic compression is the ultimate anabolic stimulus for them.
It's the go signal.
It's the go signal. It encourages the cell to increase the synthesis of aggrecan and type 2 collagen. It also shifts the balance toward protection by increasing tissue inhibitors of metalloproteinases, or TIMPs.
And the TIMPs are the good guys. They're the ones that shut down the degradative enzymes. We see this clinically, don't we?
Yes. Moderate, healthy exercise increases proteoglycan synthesis and demonstrably improves the stiffness and health of the cartilage. It's how the tissue maintains its integrity. The pressure oscillations act like the signal that keeps the production line running in the factory.
But the wrong signal static or excessive loading, it shuts that factory down.
Completely. Static compression, even within what might seem like a physiological range, is detrimental over time. It signals the cell to suppress matrix synthesis. It downregulates the essential genes for type 2 collagen and aggrecan.
At the same time.
Simultaneously, it increases the expression of matrix metalloproteinase, the MMPs, the degradation enzymes. The cell literally switches from an anabolic productive state to a catabolic destructive one.
It's so interesting that the absence of load is also detrimental. Immobilization, like in a cast, causes rapid deterioration, doesn't it?
It does. A total loss of mechanical stimulation causes a sharp decrease in PG levels. It makes the cartilage softer and much more susceptible to damage once loading is resumed.
Is that damage permanent?
Well, there's a silver lining there. Studies show that the PG loss due to immobilization appears to be largely reversible once you start moving again, once you remobilize. It suggests the chondrocytes, while they were suppressed, haven't been terminally damaged.
That's good news for rehab protocols.
It is.
So this all boils down to the clinical application, the impact of kinematics and risk. We see this all the time in our trauma patients. A soft tissue injury fundamentally changes the biomechanics of the joint, even if the cartilage surface looks totally fine on arthroscopy.
That is the critical link to premature OA. Take an ACL tear. The knee joint kinematics are immediately and profoundly altered. The load transmission subtly shifts, and it often concentrates forces onto regions of the cartilage that were never designed to handle that specific loading pattern.
So a region adapted for, say, a 5 MPa static load is suddenly getting hit with 15 MPa of dynamic shear.
Exactly, and those unadapted chondrocytes now receiving this barrage of mechanical signals they weren't wired to handle, they switch from their healthy, anabolic Goldilocks state to a catabolic destructive state.
And that's the beginning of the end.
That's the beginning of the end. Even microscopic changes in alignment, a slight malrotation, a subtle change in gait, are enough to disrupt that homeostasis and initiate the degenerative cascade. This is why addressing the kinematics after an injury through meticulous reconstruction and aggressive, careful rehabilitation is the first and most crucial step in trying to prevent post-traumatic OA.
We're trying to restore the mechanical environment.
So the cells can start listening to the correct anabolic signals again.
Okay, so if that biomechanical tightrope snaps, if the joint kinematics are disrupted, the immediate molecular manifestation is what our sources call the catabolic threat. The cells start pumping out the enzymes that just chew up the matrix.
This enzymatic degradation is the absolute hallmark of early degeneration, and it targets the two main structural components we've talked about, the collagen framework and the proteoglycans that generate pressure.
And this is mediated primarily by
the matrix metalloproteinases, the MMPs, and the aggreganeases, which are part of the ADAMTS family of enzymes.
Let's start with the degradation of the collagen framework, the pressure vessel.
Collagenases are the specific MMPs, and MMP1, NAGS8, and NAGS13 being the most notorious, that mediate the cleavage of type 2 collagen. Now you have to remember, collagen has an incredibly slow turnover rate. Its half-life is measured in years, sometimes even decades.
It's meant to last a lifetime.
It is. So when these collagenases get in there and cut those type 2 helices, the fragments that are released become measurable biomarkers, or neoepitopes, in the synovial fluid, in the serum, or even in urine.
And that's a huge area of research, right? Trying to detect those neoepitopes as a kind of early warning system for OA.
It's the holy grail of precision medicine and osteoarthritis. If we can reliably measure those collagen fragments in the synovial fluid, we can confirm the onset of collagen breakdown, potentially years before any structural loss is visible on an X-ray or a conventional MRI.
So we can identify patients who are in that early preosteoarthritic state and actually target an intervention.
That's the goal.
And then there's the other side of the coin. The loss of the hydrostatic pressure generator, the proteoglycans.
This is where the aggreganeases, the ADAMTS enzymes, are the primary culprits. Specifically, ADAMTS4 and ADAMTS5. They contribute heavily to cleaving the aggrecan core protein.
Which leads to a rapid loss of the GAG side chains.
Exactly. And critically, a collapse of that fixed negative charge density we talked so much about.
And if you lose the fixed negative charge, you lose the ability to attract water, and the entire hydrostatic mechanism just fails.
Correct. The cartilage loses its turgor, its stiffness, its capacity to resist compressive load. It becomes soft, permeable, and prone to rapid mechanical erosion. This is why the research targeting ADAMT inhibitors is so promising. It suggests we can block the specific non-collagenase-mediated cascade.
Can you give us a specific example of that targeting research?
Well, the most compelling preclinical work involves ADAMTS5 deletion. There are studies in murine models of osteoarthritis that showed if you genetically delete or inhibit the active ADAMTS5 enzyme, it entirely prevents cartilage degradation following a joint destabilization surgery.
So it offers a clear therapeutic window.
A very clear window. If we can develop a safe, specific inhibitor, we might be able to halt the progression of PG loss immediately after a traumatic joint injury, like an ACL tear.
That is a huge potential win for the future. Now let's pivot to a major contemporary clinical warning that every single orthopedic practitioner has to internalize iatrogenic injury. Specifically, the danger posed by local anesthetics.
This is a definitive practice-changing point over the last decade. We've seen documented cases of rapid, catastrophic loss of articular cartilage chondrolysis, attributed to the depletion of chondrocytes below a critical functional threshold.
And the primary villain.
The primary villain in many of these reports was the sustained or high-dose intra-articular administration of local anesthetics.
I remember the initial reports surrounding the use of pain pumps after arthroscopy. It was a huge deal.
It was, and rightly so. The sustained administration of local anesthetics, like bupivacaine or lidocaine, were shown to be highly chondrotoxic, and it was dose and time dependent.
And this isn't just a matter of the cells being unhappy, it's cell death.
It's profound, irreversible injury to the manufacturing base. Think about it. If only 1% of the tissue volume is responsible for matrix maintenance, and you kill off half of that 1% using a local anesthetic, the remaining cells simply cannot keep up with natural degradation and turnover. The system collapses.
So even a single high-dose injection can cause trouble, not just the continuous pumps.
Yes. While the pain pumps provided that sustained exposure, both in vivo and in vitro studies have shown that even a single injection of a common concentration, say 0.5% bupivacaine, can lead to substantial chondrocyte loss. So the take-home message for us clinically is extreme caution. Intra-articular local anesthetics should be used sparingly, at the lowest effective concentrations, and never in a sustained manner that bathes the chondrocytes for hours or days. We risk creating the very problem we are trying to manage, joint degeneration.
Okay, so assuming an injury happens, not one we caused, let's address the body's attempt at healing. Their response, or really the lack thereof, is entirely dependent on the depth of the injury.
That's the whole story. The depth dictates whether the tissue can access the rest of the body's repair mechanism, and that means penetrating the subchondral bone.
So, case 1, a partial thickness disruption, fibrillation, or a flat tear, damage that's confined to the surface. The subchondral bone is intact.
This is the frustrating scenario for us, because it results in no effective reparative response, zero.
Why not?
The injury site is avascular, aneral, and crucially, has no progenitor cells that can migrate in to fix it. The resident chondrocytes near the defect, they might proliferate briefly, they sense the wound, and they might try to synthesize a little bit of type 2 collagen and PG.
But they're trapped.
They're completely trapped within that dense avascular matrix. They can't migrate to fill the defect. The altered mechanical environment around the crack further suppresses their anabolic efforts, and they often just quickly undergo apoptosis, programmed cell death.
So the injury just leads to softening and accelerated progressive degeneration.
That's it. In essence, the tissue suffers a cut, but it can't signal for vascular repair, it can't deliver any repair resources, and it just leaves the damage to fester and spread.
That's grim. Okay, case 2, a full-thickness cartilage and subchondral bone disruption. This is an injury that penetrates through the tide mark and into the bone marrow.
This injury, paradoxically, opens the door for a repair effort. By penetrating the subchondral bone, you gain immediate access to the vascular system.
And that kicks off a standard wound response.
A standard, albeit imperfect, wound response. You get a robust hematoma formation, an inflammatory cascade, and critically, the migration of mesenchymal stem cells and other progenitor cells from the bone marrow right into the defect site.
So we get tissue fill, which is good. But the crucial clinical distinction is that the resulting tissue is an imperfect outcome.
Is the ultimate compromise. The resulting tissue is fibrocartilage. It fills the defect within about 6 to 8 weeks, but fibrocartilage is structurally completely inadequate because its primary component is type 1 collagen.
The same type you find in skin and scar tissue.
Exactly. It is not the specialized type 2 hyaline cartilage that was there before.
And why is type 1 collagen so inferior in this context?
Because it lacks that zonal anisotropy we spent so much time on. It doesn't have the same high fixed negative charge density from PGs, which means it can't generate and contain the same hydrostatic swelling pressure. It's essentially a mechanically weak scar patch.
I love the analogy we used earlier, trying to fix a specialized ceramic surface designed for 20 MPa dynamic loads that's hyaline cartilage with a simple patch of asphalt. That's fibrocartilage.
It's the perfect way to think about it.
The asphalt covers the hole, sure, but it's going to consolidate, it's going to fail to transmit forces correctly, and it's going to quickly degrade under the extreme pressures that were intended for the ceramic.
That analogy should be mandatory teaching for every resident. It perfectly explains the long-term failure rate of procedures like microfracture. While they introduce the necessary repair cells, the resulting tissue is so biomechanically mismatched to the joint's requirements that it leads to failure, and often progressive OA around the patch site within just a few years.
So historically, our focus was so lesion-centric, just fix the asphalt patch. But the modern understanding, which is driving all the current research, is the systems view of OA. It's a disease of the entire joint, not just a localized failure of the articular surface.
Correct. We now understand that osteoarthritis pathogenesis is this complex interplay of systemic biological factors underlying structural mechanics and the local tissue environment. It's a joint organ failure, not just cartilage wear and tear.
And this is why just addressing the cartilage defect without fixing the structural or biological drivers is just destined to fail.
Absolutely.
This brings us to the slot machine analogy, which is used in figure 27.3 to frame OA risk. I find this analogy brilliant, not just for us, but for patient education and for framing our approach to intervention.
It simplifies a complex, probabilistic disease outcome really well. Think of the slot machine as having three main levers: a biological factor lever, a structural factor lever, and a mechanical factor lever.
And if you pull the handle on the machine, the risk of developing OA is like hitting the jackpot. And that probability is reflected by how far each of those levers is pulled toward the high-risk state.
Exactly. So for the biological factor, we're talking about things like systemic inflammation, metabolic disease like obesity, genetic predisposition, and the patient's inherent capacity for matrix turnover and healing. If that lever is set high, the baseline risk is already elevated.
Okay, and the structural factor lever would be things like existing deformities, varus or valgus malalignment, meniscal tears, underlying bone irregularities.
And critically, the mechanical factor lever is the history of trauma, altered gait, or abnormal kinematic loading patterns after an injury, which is the lever we often try to correct surgically with things like an ACL reconstruction or an osteotomy.
So if you have a patient with, say, mild varus alignment who is also obese and just had an ACL tear.
They have essentially stacked the deck against themselves for developing OA. They've pulled all three levers to high risk.
So the goal of modern intervention is to delineate and treat these potentially reversible pre-osteoarthritic states before the irreversible breakdown, the jackpot, occurs. We need to identify who is pulling those risk levers and figure out how to push them back towards zero.
And that relies entirely on our ability to detect the invisible. We know that cartilage with an intact surface can recover from a subsurface injury, provided the biomechanics are restored.
But that subsurface damage, the PG loss, the early microfissures in the deep zone, you can't see that on a conventional MRI or a standard arthroscopy.
Not at all.
So we have to move into the realm of advanced imaging. Which quantitative MRI techniques are providing us with this kind of compositional view?
We need techniques that map the composition, not just the shape. So we have to rely on quantitative MRI to identify changes in water content, collagen organization, or PG density. This includes techniques like DG-Muraic, T-Wart mapping, or UTET2 mapping.
Can you quickly break down what those are measuring for us?
Sure. DG-MRI uses a charged contrast agent that gets excluded from the cartilage based on the fixed negative charge density of the PGs. So less PG means the agent penetrates more easily, giving us the quantitative map of proteoglycan loss.
NTR.
TPRO is sensitive to interactions between water molecules and the surrounding matrix macromolecules. It also indirectly signals PG loss and structural disruption. But UTT2 is perhaps the most sensitive.
Why is that?
It uses ultra-short echoes to pick up signals from the bound water fraction, the water molecules that are closely associated with the collagen network. This provides a really detailed view of collagen matrix organization and integrity, especially down in those deep zones.
This is how we detect a problem before it shows up as a visible surface defect. And the clinical payoff is huge, as it's shown in figure 27.4.
Oh, figure 27.4 illustrates the power of UTET2 mapping beautifully in a post-ACL injury context. If you look at panel A and B, you can see this modeled high-signal pattern in the deep cartilage and meniscus just after the ACL tear.
And that modeled pattern is the sign of damage.
That's the sign of underlying structural compromise. PG loss, collagen disruption. Stuff we would have missed entirely on a standard T2 image.
And the staggering part is the potential for recovery.
Yes. Look at panel C and D. This is the same joint 2 years after a meticulous anatomic ACL reconstruction. The cartilage and the meniscus show a remarkable reversal of that damage.
The signal is returning to normal.
The deep tissue signal returns to a low laminar pattern, comparable to uninjured controls. This is clinical evidence that if we restore that crucial mechanical factor lever, if we stabilize the joint and restore natural kinematics, the native tissue, provided the surface remains intact, retains the intrinsic capacity to recover from significant subsurface injury.
That shifts our entire clinical approach.
Hmm.
We're not just trying to prevent further damage anymore. We are actively facilitating native healing by correcting the mechanics.
Absolutely. The future of treatment is about facilitating those native pathways of healing immediately after the injury or the onset of abnormal loading. And this leads directly to the future directions of research.
So we need to augment this inherent repair capacity and prevent progression to that final irreversible OA state.
Precisely.
So what are the two main fronts of research we're pursuing?
First, targeted pharmacological and biological treatments, chondroprotective agents. We're investigating targeted inhibitors for the catabolic enzymes, like MMP inhibitors or ADAMTS inhibitors, to block that degradation cascade instantly.
At the same time.
At the same time, we're looking at delivering concentrated doses of anabolic growth factors, TGF-beta, IGF-1, BMPs, to stimulate synthesis in that surface intact but compromised cartilage.
The idea being you inject the right biochemical signal to shift the chondrocyte factory back into production mode, even if the mechanics are still slightly off.
Precisely. We are fighting the biological factor in the slot machine. And the second front is functional tissue engineering. This is the hard problem, developing techniques that move beyond the type 1 fibrocartilage patch.
We need to create a patch that truly functions like the original ceramic, not like the asphalt.
That means developing sophisticated scaffolding and cellular implantation techniques like advanced stem cell therapies or augmented microfracture that not only restore the volume, but restore the essential functional zonal structure. The patch has to integrate seamlessly with the surrounding matrix and exhibit that anisotropic collagen orientation and the specialized PG density required to handle 20 MPa dynamic loads hydrostatically. That is the holy grail.
This has been an incredibly detailed and I think very necessary exploration of articular cartilage. It's a tissue that forces us to reconcile its marvelous mechanical resistance with its fundamental biological vulnerability.
The key takeaways are crystal clear. Cartilage longevity hinges entirely on its anisotropic structure, that specific zoning of collagen fibers we talked about, the parallel, oblique, perpendicular, and the successful maintenance of biomechanical homeostasis.
Right. And the chondrocytes are essential, but they're incredibly sensitive. We have to respect the clinical danger of local anesthetics, which can lead to that rapid iatrogenic chondrolysis.
And crucially, healing capacity is dictated by injury depth. Partial thickness injuries, they don't heal, they just degenerate. Full thickness injuries heal imperfectly, resulting in that biomechanically inferior type 1 fibrocartilage.
The asphalt patch.
The asphalt patch. But the exciting frontier is this shift to systems thinking. OA is a whole joint disease, and the discovery that we can use advanced quantitative imaging to identify and actually reverse subsurface damage after fixing the joint mechanics. That means we can intervene in the pre-osteoarthritic state. It offers real hope to our trauma patients.
And that intense reliance on the mechanical environment, the fact that the synthesis line only runs when the signal is dynamic and it shuts down when it's static, that leaves us with the ultimate engineering puzzle, something for you, the listener, to mull over.
If we know that static compression suppresses synthesis while dynamic multiplanar loading simulates it, how can we possibly replicate that complex variable loading, not just in a laboratory bioreactor, but in the clinical reality of rehabilitation, to successfully guide a synthesized cartilage patch toward achieving the required anisotropic, zonal, and highly functional structure of native articular cartilage?
It's the challenge of replicating life itself. Thank you for joining us for this deep dive. We'll catch you next time.